Hello everyone, thank you for joining me today on this webinar to do a deep dive into the measures that make up the at-risk populations domain of the Centris Health MSSP ACO. My name is Cindy Campbell and I am the Director of Clinical Strategies with KCMPA, and I'm also the representative and the liaison between Centris Health and the independent practices that are a part of Centris Health. To find these recordings and all of the recordings that have been created for the MSSP ACO, if you just go to the KC Metro Physicians website at kcmetrophysicians.com, and then if you just move over to the the right-hand side, you will see a menu bar with the social media. And if you click on YouTube, it'll take you to the YouTube channel, and there you can find all of the recorded webinars. So this slide here shows the number of clinics that make up the MSSP ACO and the number of attributed Medicare lives for each of those clinics. And this will change, the number of attributed lives will change over the course of the year. This is what we were sent by CMS at the beginning of the year, and then this will change through the course of the year as there's patients that will either age in or they will fall off due to death or being attributed to another clinic or to another provider. We estimate it changes about 20%. And this slide here shows the number of measures and the different measures that make up the MSSP ACO. We have 4 domains and 31 measures that would fall into one of each of those 4 domains. We have already done a webinar and covered patient caregiver experience, care coordination and patient safety, and then preventive health. And so today we will be talking about those measures that fall under the at-risk populations domain. Each of the domains is 25% of the total weight, and this slide here shows the number of measures that make up each domain. And so it doesn't matter how many different measures fall into that domain, each domain is still weighted equally at 25%. Okay, so let's jump into the measures, the 5 measures that make up the at-risk populations domain. So we have depression. ACO 40 is the depression remission at 12 months. And then we have the diabetes composite, which is ACO 27, hemoglobin A1C poor control, and ACO 41, diabetes eye exam. So it should be noted that even though these 2 measures are 2 separate measures, and we do aggregate data separately for each one of these, they actually end up being scored as only one measure. So it's an all or nothing composite is how CMS refers to it. So then we have hypertension. ACO 28 is controlling high blood pressure. And then ischemic vascular disease. So ACO 30 is the use of aspirin or another antithrombotic for those patients who have known vascular disease. So just a few points about the measures for at-risk populations that we should point out is these are measures that are all pulled directly from your EHR. As you recall from our previous webinars, that we have 3 sources where we pull measures from, and that is the patient experience surveys or the CAP scores, and that data will be is one source, and then the claims data is another source, and that's really around our readmissions and admission data. And then we have the EHR or web interface. So when we go to actually collect the data for these measures, we will be sent a patient sample file from CMS. So we don't submit data on every single patient that's attributed. However, we just receive a sample file, and then we will reach out and we will be working with those individual practices that has that attributed patient to pull this data. So looking at this data, or looking at these measures, this is really measures that fall under population health. And most of our, if not all of our primary care practices, they are already working on these measures. They're already built into their daily workflows. And this is just a normal kind of part of their delivery, of their patient care delivery, is accumulating this data and documenting. So performance year number 1, which is our current year, we are in performance year number 1 of the MSSP ACO. So all of our measures are pay for reporting only. It is not pay for performance. It is all pay for reporting. So for the at-risk populations, performance year 2 and performance year 3, the ACO number 40, the depression remission, will always be pay for reporting for those next 2 performance years. All right, so let's go ahead and jump into our deep dive. So ACO 40, and the NQF number is on each one of these slides. If you want to go into the NQF and see what where CMS has received their recommendation guidelines from, then you can go in there and you can read it. So this is NQF 0710, depression remission at 12 months. So this is looking at all of the patients 18 or older who have had a positive depression screen. So most of the practices, most of the primary care practices, if not all, are doing a depression screening on each patient. And if that patient comes up as a positive screen, then they need to have some kind of a plan that is put into place. And then that patient needs to be re-screened, and then they need to be shown that they have had a depression remission. So a lot of times you will see that the plan is that they have a referral to some type of behavioral health, or they're put on an antidepressant. So let's just talk a little bit about how this is being done. So a lot of the practices just do an initial, very simple PHQ-2. So that's kind of their, a very quick and dirty way of assessing whether you need to do kind of a further assessment into a possible diagnosis of depression. So a PHQ-2 is just a simple 2-question assessment that asks if the patient has felt down or depressed or hopeless recently, or if they felt little interest or pleasure in doing things. And if they test, or if they say yes to any one of these, and then that spurs the clinic and the care team to then do a PHQ-9. So based on the response of a PHQ-2, that would then trigger the care team to do a PHQ-9. And then if the patient has a score of greater than 9 on the PHQ-9, then they would have a diagnosis of depression, and that would be our denominator. And then our numerator would be taking that list of patients, and then was that PHQ-9 reissued within 12 months. So that takes a little bit of some timing and some calculation, and ensuring that those patients get back into the clinic and that they are then re-screened for depression. So our next measure is ACO 27, And this is the first measure of the two that make up the diabetes composite. And this is hemoglobin A1C poor control. And this is looking at all of the patients that are 18 to 75 who have had a diabetes hemoglobin A1C measured within the past year during that measurement period that's greater than 9. So our denominator is going to be all of the patients with diabetes. So it will be between 18 to 75. And then our numerator will be all of those patients that are with diabetes that have a hemoglobin A1C greater than 9. So this is only going to be those patients that are a type 1 and type 2 diabetics. It doesn't include anyone that might have a high hemoglobin A1C because of another factor. Could be things like, steroids or some other factor. But a little bit of a tricky piece about this is it's going to be an inverse ratio. So the lower your number, the better. So the lower the numerator is, the better it is, because you want to have a lower number of patients that have a hemoglobin A1C greater than 9. Diabetes eye exam. So this is going to be looking at that same group of patients that are 18 to 75 who have diabetes, but that they've had an eye exam. So once again, the denominator would be all of your diabetics 18 to 75, and then your numerator is going to be those patients that had a diabetic eye exam done. This is a little bit of a tricky and a harder to achieve measure, and the reason why is because the report actually has to be on the record. So it cannot just be something that the patient has verbally said, I had it done. They have to actually have the report sent to the clinic and on their record. It has to be performed by an ophthalmologist or an optometrist. And just like the hemoglobin A1C, it's only going to be for those type 1 and type 2 diabetics. So the hard part about this is making sure that some good care coordination is happening and that those patients understand when they go to see their eye doctor for their diabetic eye exam that they have to have that report sent to their primary care practice or their primary care physician. So doing some good education with those patients. Some of the practices that I'm working with have created some forms that have, this is what you need to do. It gives very clear instructions about when you go to see your eye doctor. Please make sure that they know this is your primary care provider, and please make sure that they fax or send the report to this number. So the next measure is ACO 28, or hypertension or controlling high blood pressure. The description for this is those patients 18 to 85 who have had a diagnosis of hypertension that's been adequately controlled. So the denominator would be all of your patients within that age group who have a diagnosis of hypertension. And then your numerator is going to be all of those patients with in that group that have a adequately controlled blood pressure or blood pressure that is less than 140 over 90. So we would be going in there and we would be actually looking at that. We would be pulling those patients that have that diagnosis code, and then we would be looking at their last blood pressure. So the exclusions for this would be those patients that have end-stage renal disease, dialysis, a renal transplant. ACO 30 is ischemic vascular disease and the use of aspirin or an antithrombotic. This is all of the patients that are 18 or older who have one of these diagnoses. So an acute MI, a coronary artery bypass graft, a percutaneous coronary intervention in the past 12 months, or if they have an active diagnosis of ischemic vascular disease. And they have to have a documentation that they have use of an aspirin or an antiplatelet, antithrombotic, antiplatelet medication. So the denominator would be all of those patients that are 18 or older that have one of these types of vascular diseases. And then our numerator would be those patients, out of those patients, which ones are on medication or an antiplatelet. And that is the end of this webinar. That comes to the end of the 5 measures that make up the at-risk populations. If you have any questions, please don't hesitate to call me or to send me an email. This is my contact information, and I'm always happy to discuss any of this and answer questions. I appreciate your time today. Thank you.